Welcome to the podcast for Healing Neurology, where we talk about everything that can help heal your neurology, which is really everything from food, lifestyle, and medicine to nature, culture, and politics. There's no topic too big or too small. I'm Jillian Ehrlich, family nurse practitioner, certified in Ayurveda and functional medicine. And I am thrilled with who we have here today. Dr. Emily Gutierrez is a DNP, CPNP, APRN, PMHS, and IFMCP. So basically, she has a doctorate in nursing practice. She's a specialized pediatric nurse practitioner, and she's also certified in functional medicine as well as nutrition. That's what all those big fancy letters mean. It means she's brilliant and she keeps learning. She loves learning. So she received her doctorate from Johns Hopkins University with a focus in translational medicine and integrative health. She is also a certified practitioner through the Institute of Functional Medicine. Dr. Gutierrez received her master's degree in nursing from the University of Texas at Austin and is board certified as a pediatric nurse practitioner and mental health specialist through the Pediatric Nursing Certification Board. Dr. Gutierrez is the founder of the Integrative Health Special Interest Group for the National Association of Pediatric Nurse Practitioners and is a seasoned speaker, writer, and researcher. She has completed the dietary supplement practicum with the National Institute of Health and is also adjunct faculty in the Johns Hopkins School of Nursing. She incorporates functional nutrition, genetics, immune, and environmental health into providing individualized medical care for her patients. You can find more about her at her website, neuronutritionassociates.com. And upcoming, we're recording here in May of 2022, but as of July 2022, her specialized supplement formulations will be up and running at the website neuronutrients.com. So please do check that out. As we were just talking about, it's very hard to find supplements for kids, and we're going to talk a lot about more of this today. So let's dive in. Dr. Gutierrez, welcome. We're so happy to have you.
Thank you. Thanks for having me. Isn't it funny how us nurses have a bunch of alphabet soup behind our names?
Yes. I mean, but it's part of the learning. It means that, you're not just getting one degree and sitting in it. It just shows how much more you've had to learn and how hungry you've been to treat patients really well, to treat kids really well. So thanks for all the work that you've done in the world to learn all that. And thanks for all the kids that you see, all the patients you see.
Oh, well, thank you. Well, I'm excited to dig in and talk all things neurology for kids. And if you have anything real particular like autism we want to jump into, I'm happy to do that.
Awesome. Yeah, let's start there. You did write a book, The Parent's Roadmap to Autism, published in 2018. So if you are super excited today about this topic, that book can be really instrumental and helpful. But let's start with like this big umbrella. When we talk about neuroimmunology disorders in kids, tell us how you think about that.
Well, I think it's a huge paradigm shift because, traditionally we would say, okay, so you have troubles with executive functioning, you can follow two-step directions, you easily forget, you're kind of hyperactive, there's a lot of impulsivity. Well, you must have inattention disorders. And, allopathic wise, we're really good at identifying and diagnosing it. And the treatment is purely pharmaceutical, right? Stimulants, non-stimulants are some kind of out-of-the-box drugs for ADHD, but it's like, no, let's ask the question, why? Why does this kid, why was there a trigger for an inattention disorder? What happened along the way? And I think what's really exciting about pediatrics and neurology is there is quite a new acceptance in allopathy or mainstream medicine that, hey, actually the systems in your body interact with each other and can present, pathology, presenting things in the brain like inattention disorders. And hey, the immune system actually is a big, big part of that as well. So I think there's becoming a better recognition that, when you have a disorder, there could be another cause for it rather than, a Ritalin deficiency, that there might be something else we need to start looking for.
And can you walk us through some of the diagnoses that kind of reflect the neuroinflammation for kids?
Yeah, one of the diagnoses that's kind of, it just pulls on my heartstrings is OCD. So, OCD, a sudden onset or a sudden onset of tics and OCD, I very, very much think, well, what was the infection, 2 to 3 months before this happened? And it's not uncommon that I've had patients that will do stuff like, look to see if they have mono or strep or some infection happened, and all of a sudden, their OCD is so bad they can't get out of the house and they have these tics that the pediatrician sometimes just says, oh, that's normal in childhood. You're ticking, they'll go away. You just need to wait. But the parent is like, oh no, this isn't normal for my child. Like they've never had a tic before, and this is very upsetting. Please help me to figure this out. Mm-hmm. So, things like OCD, definitely other forms of encephalopathy, things I'm sure you've heard of PANDAS, which is pediatric autoimmune neuropsychiatric disorder related to Streptococcus. And then we've shortened it to PANDS because, it can be more than just strep. It can be other infections, like if you get the flu. And then if you get the flu and you get pneumonia and you have mycoplasma, or if you're bitten by a tick and you have Lyme, or even things environmental, like if you're living in a moldy building over time, that kind of toxicity can cause some inflammation and stress on the brain. So in my practice, I do see a lot of PANDAS and PANDS, see a lot of autism. I see a lot of depression, anxiety, OCD, and then we'll definitely get the eczema child or the kiddo with chronic diarrhea and irritable bowels, which are really fun for me because I'm like, oh, this is going to be a home run. And it's going to be pretty quick.
It's so interesting. And just to contrast against what happens with neuroinflammatory conditions in the elder years, then you're seeing neurodegeneration like Alzheimer's or dementias or Parkinson's. And so this is kind of like at the beginning of life when, the cells are new versus the cells are kind of older. They've had older. So this is interesting. Let's dive into autism a little bit. How do you define autism?
Well, it depends on who you ask how you define it. And I did a little research today preparing for this podcast. And it's interesting. The Centers for Disease Control says autism spectrum disorder is a developmental disability caused by differences in the brain. So that's the CDC, where the American Academy of Pediatrics says it's a common neurodevelopmental disorder that is identified through 2 domains: social communication, interaction, and restrictive repetitive patterns of behavior. So I don't know if there's a consensus to how you would say this is autistic. My own definition is it's a developmental disorder that's characterized by particular behaviors such as repetitions. A lot of times these kids go inward. They have social communication deficits. They might do stuff like starting to line up toys, becoming very rigid, a lot of sensory sensitivity. Some kids regress. They've hit milestones and they're doing things like hugging and speaking and making eye contact. And then they have a period of regression where they lose milestones. And then other kids just never really reach those milestones. Like they never really start talking, or very delayed in walking. They're very delayed in their milestones. And then of course you have to add spectrum on top of it, right?
Right.
Because it's a beautiful description of autism, I think, because you do have your very severely autistic patients that will never say a word, that might not ever become potty trained, that will need 24/7 care for the rest of their life. And then you have this high spectrum, really intelligent little kiddo that is, very hyperactive, a lot of comorbidities with ADHD, dysgraphia, and then just hard to sit still, hard to kind of be in the mainstream classroom, that, has this problem with also making social connections. Like the social piece is really hard for them as well, but they're going to live independently. They're going to be on their own. They're going to get a job and they're going to be on their way with some challenges. So it depends. It depends on the child, and it depends also how well that child does typically when they are diagnosed and when you start to recognize that there's symptoms of autism that the child is starting to display. And
so is there a certain age? I mean, obviously, everything we're going to talk about today is going to be along this spectrum, but are there particular ages that these symptoms present at?
Okay, so standard of care for anybody in pediatrics, you're supposed to do an MChat. And an MChat is a way that you start to ask questions like 18 months and 24 months. You're supposed to do in primary care when you have a well check, your pediatrician is supposed to be giving you a questionnaire. And you do that checklist. And if you score high, you're supposed to be watched or referred. And typically people that diagnose autism are developmental pediatricians, they are neurologists, they can be neuropsychologists. But in a lot of places, it's just the pediatrician, because that's really the access to care is the pediatrician. And, some people are really rigorous with the diagnosis, meaning they'll do something called an ADOS, which is an autism diagnostic observation schedule. Like they have a professional that will do that. And other people just kind of give a diagnosis because they're seeing enough symptoms that they make it without a lot of the formality that's involved. Mm-hmm. So I think it's really important for a diagnosis for services. So for example, if you're going to get that child applied behavioral analysis therapy, ABA therapy, or speech and OT, you need a diagnosis for your insurance to cover it, especially ABA, because it can be really, really expensive if you don't have it. But it's a lot of times it's kind of loose as to how somebody is diagnosed.
How do you separate these, like an autism diagnosis with those behaviors, from trauma or do you? How do you do that?
That's a really good question. I think we have to make the determination between regressive autism and autism that is kind of present from birth. So the type of autism that's present from birth, like they never really made a milestone to regress from, or they had global developmental delay. I think that what's really, really important with those kids is that you get a chromosomal microarray done and a Fragile X. Mm-hmm. So these are genetic things that look at how the structures of the chromosomes are, because that can be something that's from birth. I always think of genetic, especially if somebody has like phenotypic characteristics that are not normal, right? If they look different. I think that every child that has a delay from the beginning deserves one of those. And I tell you, my practice, there's been times where I've had kids that were diagnosed with autism, never had that before. And with me and all my autistic patients, I want to have that it's just basically a checklist of reassurance for the most part. Mm-hmm. And I've had kids come back for Fragile X more than once, and they were missed. And the reason that you want to know it's Fragile X and not autism is because what you can expect along the way of their life is more predictable. And you can say, for somebody that doesn't have a chromosomal thing, and maybe it's other genetic things, but not particularly chromosome or Fragile X, they could show a lot of improvement over their lifestyle. But somebody that has a chromosomal thing, you have predictions along the way. Like you might need to be checking, their thyroid more, or do imaging on their heart. Like it's good for expectation and for just kind of care in the future of what to expect. Mm-hmm. So those are the kids with global. Kids with regressive autism, Dr. Fry is probably one of my favorite persons that I follow. I don't know if you followed any of his work, Dr. Richard Fry, mm-hmm. but he talks about 20% of autism is genetic, and the other 80% has these three big characteristics from it. And that is oxidative stress or redox stress. So meaning that there is a lot of physiological stressors on that child, or it's due to major methylation deficiencies, meaning they're not getting the folates they need into their brain, into their nervous system. Mm-hmm. And then the third one is really mitochondrial stressors. Mm-hmm. So, which you can imagine, redox, oxidative stress, and methylation is going to lead to mitochondrial stressors. But there are some people that's kind of their major presenting symptom. So when you have regressive autism, I really key in on those three things because, if you regress, often you can get those milestones back. But really the big take home for everyone that's listening is the earlier the intervention, the better the outcome.
So with autism versus PANS or PANDAS, kind of some of these other neuroinflammatory, do you think of Dr. Richard Fry's like three things with that as well? The 80-20, do you think about that with PANDAS and PANS, like vulnerability?
Well, I think we all have our genetic vulnerabilities, right? Mm-hmm. The whole saying, the genes load the gun and the environment pulls the trigger, is just so accurate. Mm-hmm. So yeah, what was the environmental trigger that made somebody present with PANS or PANDAS? And the truth that is very evident to this, to those that treat autism and PANS, is there is a lot of overlap with autism and PANDAS. And if you are autistic, you are way more likely to develop PANDAS than if you are normally, typically developing. And I don't know if that link is really elucidated, if we know exactly why, other than looking at, Dr. Fry's 3 kind of major things of oxidative stress, methylation, and mitochondria. So the truth is that, these kids that are autistic that aren't recognized that there was a PANDAS component to it, they're often just being prescribed more antipsychotic drugs, and people aren't looking for infection, which is a big disservice to these children and these families. And I'm hoping that changes, and there's more and more awareness around that. If you're autistic, you're more likely to develop PANDAS or PANS. It doesn't mean that you will. It just means you should be looking for it if there's an abrupt change in behavior.
Especially in that timeline, 2 to 3 months after some sort of infection, like a flu or a virus or a COVID.
And the whole thing is sometimes you don't know that there's an infection. And that's the key part, because if you have a child that all of a sudden has been potty trained and starts having urinary accidents, bedwetting, urinary frequency, and has a lot of obsessional things, becomes very, very, has a lot of you can't leave the room, there's separation anxiety, they want to sleep with you, they could have strep, but they might not have a sore throat. They might not have a fever. They might not have big tonsils. So, when they go into the pediatrician, they're often not looking for infection. It's like maybe we need to put you on Prozac. Mm-hmm. So that's sometimes you don't know that there's infection. And that's the tricky part, unless you're trained to really watch for psychiatric symptoms can have an immunological basis that needs to be ruled out before you just stick a kid on meds. Because maybe the med is amoxicillin, not, fluoxetine or Prozac.
Which is the same in I don't know why I'm thinking about elders today, but it's, the ends of the spectrum. We all know in primary care with elders, a UTI often presents as confusion. If an elder is confused, check their urine. That's well established. Every conventional practitioner around the planet is going to have that on their differential, on the radar.
Yes. I love that. And there is a lot of similarities between neurodevelopmental and neurodegenerative. You can apply a lot of the same principles. So you're not wrong to be having those 2 spectrums in mind.
Talk to us, just because we're on this topic and it's so fascinating. When you look for infections in these kids, what infections are you looking for?
That's a great question because, there's a long list of them, right? Mm-hmm. There's a long list. There's some pretty common ones. I mean, strep is the most common. And here's the deal. If you go to the pediatrician and you get your kiddos swabbed for strep, especially if they're really combative and, getting a swab is hard, it might not come back positive on that rapid swab. So we can run a rapid in 5 minutes and know if you have 2 lines and all of a sudden you have strep throat, they have to culture it. So they have to smear it on an agar plate, sit it in the lab and watch it grow to make sure group A hemolytic strep does not grow out of it. So anytime you get you got to culture it and wait 2 days and see. And then strep can be on other places on a kid. So it can be in soft skin. It can be in the nose. I've actually found strep in sinusitis before, group A strep in the nose. And then it can be in the gut. And then it can also be around the anus. Mm-hmm. So that's something that even, mainstream pediatricians should be looking for is there's a red ring around the anus. You can do a rapid strep test on it and culture that as well and find strep. So strep is a big one. And just so I say it for your audience, every single time a kid is treated for strep, please change their toothbrush 2 days later. Because strep lives on inanimate objects. So, you could just start reinfecting yourself over and over again. And if you have a kiddo in your house with chronic strep too, everybody in the house needs to be checked. Like parents need to be checked, siblings need to be checked. And, everybody needs to make sure they're changing out the things that they put in their mouth, whether it be a mouth guard for hockey or whatever. So we're not just constantly passing it around. Mm-hmm. So strep is huge. Strep is big. You can test the blood for strep. You can test something called an ASO or a DNase titer. But here's the deal is, those rise and fall as a strep infection comes in most of the population. So you will have a rise in your ASO and your DNase for about 3 months, and then it starts to come down. Mm-hmm. However, I can't tell you how many kids that I've checked their strep titers for, and they're sky high, and parents don't ever remember when they got a strep infection. To me, that's evidence that we should treat with an antibiotic. And then here's the catch-22. That titer might not ever come down fully to baseline. So you can pump them full of antibiotics, but it might just never resolve. So some people end up taking out the tonsils. Some people just keep doing more and more antibiotics. That is not my style. I don't like to just keep doing antibiotics because I know it can have a deleterious effect on your microbiome. So typically we do something from 14 to 30 days of antibiotics, which I know for some of your listeners, maybe they're aghast from that. I'm pretty aghast when I prescribe them for that long, but then we stop. Then we stop and we've got to do other things. Even if you get your tonsils out, only about 20 to 30% of these kids get better from a tonsillectomy. And the older you are, the harder a tonsillectomy is. So there's that. And then there's other common pathogens. So influenza can do it. Epstein-Barr can do it. Mycoplasma, that sticky bacteria that you get when you get kind of a walking pneumonia, that can do it. Candida and fungal overgrowth can do it. Herpes virus can do it. And, Lyme also can do it. So I think those are probably the big ones. I'll do an initial assessment on those. And then I don't know, in some cases, we'll just end up doing empiric medications. Because, can you really test for every single thing that it might be? It's really hard. It's hard. And it's a lot of blood for a kid. It's like, well, now you're going to go back to the lab for the fourth time to check for more infection, and here's what we have to treat infection. And tell me if you have something different too. It's antibiotics, it's antifungals, and it's antivirals. And then there are really cool things that are just, we're figuring out that are kind of outside of the box, some meds that we can use as well. But those are our three big categories to treat infection, right?
I think the other flip side, which we'll get to in terms of treating infection, is there's the killing part, and then there's also the resilience part of the body. And so we'll get there, but that's the other way to do it. Sometimes with especially things that we know linger, like EBV or Lyme, Epstein-Barr virus or Lyme, I think about we have to kind of make friends with this organism. Like we know that viruses often don't leave the body, so we want to knock them down to where the body can essentially take over and put it in its place. And so using things like, this is perfect transition into talking about oxidative stress, methylation, and mitochondrial support, because those are the ways that your body can take over and can really keep it contained, like in a tiny corner, as opposed to rolling through unfettered through your system.
Yeah, I love that you said that, because you're absolutely right. And I think back to Martha Abair. So she's a Harvard physician. Are you familiar with Dr. Abair?
Oh, I don't know her.
So she's one of the original functional medicine pediatric neurologists, kind of looking at the brain in children and neuroencephalitis, et cetera. So she's published and talked a lot about the body burden, that, we're all on the spectrum of health, right? Say 0 is perfect and 10 is death. And there's some type of tipping point for disease, and say it's 8. So, getting strep for some of these kids might, push them from 8 to 9, and all of a sudden they have a PANDAS presentation. So my work as a functional medicine, provider is to unpack the body burden. So what does that look like? It's different for everyone. If you're allergic to dairy and you're eating it, that's contributing to your burden. If you have a lot of glyphosate in your system, that's contributing to your burden. If you're not pooping, if you're not sweating, if you're not moving, if there's trauma, it's very comprehensive. And if you unpack the body burden, then often you can reverse the chronic system and then live in harmony with Epstein-Barr and, all the other things that you're going to be exposed to throughout your lifetime.
Yes. And that is a good point, because we can't live in a bubble, really. I mean, there's things, there's choices that you can make about, do you go in the ball pit at McDonald's or not? But ultimately, the
answer is no.
I know.
Oh man.
I know. But, ultimately we are going to encounter, and our goal for our patients is to have really big lives, that if their life goal is to go in the ball pit, that eventually that we can get them strong enough and resilient enough to do that.
Yeah. And I love you use the word resilient, and it's about increasing resilience, right?
Yeah.
And the more resilient we are, the more that we can encounter, stressors, both emotionally, both, chemically, biochemically, microscopically, and we can thrive. And that's, a lot of providers are scared to treat pediatrics because they're like, oh no, they're little people, I'm going to mess them up. But I love pediatrics because, gosh, kids are so resilient. They bounce back. The kid that looks like they're on their death's door and they need to be hospitalized, and 12 hours later, they're playing, they're jumping around, they're fine. Kids are resilient. They're resilient. You give them the right tools, and most of the time they can bounce pretty well.
And I also love working with kids because they're not savvy enough yet at faking it, like most little kids, especially, So you can tell what their mind is doing by how their body moves. And I think about this at one point, my son, when he was 4, was jumping on a trampoline and twisted his knee. And he just was like, oh my God, my knee hurts. And here he is limping around. And I knew that he gets worried about his body, or at that point in time, but I knew that he was okay. And so finally I just said, I had some sort of treat. He was with his cousins and I held it up and he just came running. Like he just forgot, he forgot. And so with kids, you can really kind of see by looking at their bodies how they're feeling and what they're thinking.
Yes, I like that example. Absolutely. And I think it's really important for them, especially when they're dealing with something chronic and serious, that they know it's not their fault. Yes. They didn't do anything to cause it. I mean, I can't tell you how many times I've sat knee to knee with a kid and looked him straight in the eye and said, none of this is your fault. And you can just see the relief wash over them. Because sometimes, that's what kids do. They manifest the stress of the parents into somehow that they've done it and they've caused it, right? And I think that's a real important thing for parents to be, not let their kids absorb their stress around the illness that their kid is going through, and to be the calm leader of, you've got this, I've got this, everything's going to be okay. Because developing an anxiety over health is really, there's a big vulnerability in this space.
Oh, I'm so glad you said that, because for parents who are listening, I'm sure there's not a lot of 4-year-olds who are seeking out our podcast today. So for the parents who are listening, it's a good reminder to watch how you communicate with your kids about what their health conditions are. That's a fabulous reminder. Thank you. Let's talk about that 80% for these neurodevelopmental disorders. Talk to us about what is oxidative stress? How do we measure it? What can we do about it?
I think of oxidative stress as like an interior resting in the body. It's something that's causing a physiological or body stress that your immune system and your biological processes are having to reckon with. So, I think of everybody pumping gas. When you pump gas, especially in Texas, man, it can get really hot here in the hundreds in the summer. And you can just see the petrochemicals and the fumes coming off of that spigot. And you're standing there. I mean, that's stressful for your body, breathing in all of those chemicals. So it's about the stress about what do we have that we shouldn't have in our bodies that we're really trying to fight and detoxify and get out. It's kind of funny, right? Because in allopathic medicine, we're not taught a lot about a detox. It's kind of a quack word to say, oh, I got to go on a detox, but it's so important. I mean, think of the world that we live in. We live in a world full of chemicals. We live in a world full of chemicals, not only in our air, but in our food and our soil. So detox has to be, something that a kid does efficiently to lower their oxidative stress. And how you detox, it's really simple. You poop, you sweat, and you pee. That's how you do it. And then you can do it through respiration too. So you do, detox through respiration. So some kids, number one cause of abdominal pain is constipation. So a lot of kids aren't pooping well. And there's a variety of reasons for that. Maybe they're eating foods that they're sensitive to. They have yeast overgrowth in their gut. They have minerals that are super deficient in their nutrients like magnesium. They don't have enough. They don't have any fiber. They're not drinking enough water. So oxidative stress is really, what is your total toxic load? What are the toxins that your body's trying to reckon with?
And how do you measure for them? How do you know that they're there?
Well, it depends. There's clues both clinically and then on laboratory values too. So, eczema, for instance, is a good clinical sign that there's something that's really stressful for that body that is reckoning with, right? And, eczema can be an inflammatory process from gut dysbiosis, from foods you're allergic to, but it can also be from a toxicity, something you're putting on your skin, you're breathing in. There's flame retardants on pajamas. They do that on purpose, right? So if the house goes up, the kid doesn't go up in flames, but man, that's stressful for your body. So in my practice, we do labs. I think you'll probably agree that functional medicine people like their labs, just so we can measure where are we beginning? Where are the stressors? Where are we beginning? So when I do a toxic profile on a child, I typically check for heavy metals, I check for environmental toxins, and a lot of times I check for mycotoxins or toxins that come from living in water damaged buildings.
Do you look at some of those oxidative stress markers like glutathione and CoQ10 or 8-hydroxydeguanase? Do you look at any of that, or lipid peroxides?
Sometimes I do. I mean, I certainly would say if there's any liver, elevation enzymes, that would be something that you would kind of further look into toxicity. Glutathione, everybody I've ever checked a glutathione level and it's low. Everybody. I like looking at organic acids. I think those are helpful. Parents love organic acids because it's wake up and pee into a cup. They don't have to go get the dreaded needle for that. So I like looking at that. I like using Great Plains for their toxicity profiles too. I think they do a good job with it. So not a lot of blood markers. In pediatrics, you want to really, it's gold, right? You take a child to get a draw and you're like, I'm going to get 4 tubes, maybe they'll be able to draw that 5th one depending on their weight and age. So there's things you just can't get. I got to get their thyroid, look at their liver enzymes. I want to look at their cholesterol. I want to look at their homocysteine. So I get, unless we go back several times and then you add infection on top of the normal stuff that I usually do, you're going to say you're going to go back at least twice. Right. And for some kids, it's no big deal. Here's my arm, draw it, I'm out of here. No big deal. But for some kids, it's medical trauma. Yeah. So it's medical trauma to do it. So I'm very choosy. Over the years, I've become very choosy on what I decide to do blood work. Right. But the only good ones to do in an adult. Do you find efficacy with looking at glutathione levels?
Sometimes. And I agree. I often don't draw on kids. Genova has a panel that's just a finger poke. So sometimes I can look at some of the oxidative stress markers in the finger poke, but even sometimes that's too much. So sometimes I do and sometimes, but usually I don't. Usually I just assume that is there and then we treat from there.
Yeah. Yeah. A lot of the time, even with the CMP or the complete metabolic profile, you'll start to see signs of toxicity in there. Any type of kidney or liver dysfunction. I always think about toxicity. And when you draw a lead level, it is, actually, I like to do a urine heavy metal panel. And a lot of times CPL, LabCorp, Quest, they have panels that can be covered through insurance. So that's really helpful. Man, when you look at arsenic, mercury, and lead in the urine, you surprisingly find it more than you would think you would. So yeah. I like looking for that. Yeah. Now, metals are a two-tailed story though, right? Because we look at what's current, but then there's also the story of what has been stored in the tissues and bones. How do you like to look for metals in your patients?
So again, with kids, I may or may not. I like the LabCorp panels or the kind of the conventional testing because I feel like we've covered that base and then I can just work on detox. I also know that we're not going to really do anything about metals until a kid is peeing, pooping, sweating. All of those things are
happening. So you're such a good provider. Yay. Oh, yeah.
Good. So we've been trained by good folks. That is, that it's been a blessing. I feel really blessed. And then the other piece with metals is I know, and I do believe that oxidative stress is cumulative or collaborative. I don't know how else to say it, collaborative, so that heavy metals and mycotoxins and viruses and infectious organisms all glom together. So when the system, and the way that I kind of describe it sometimes is if you've got a recess playground and you've just got one loud bad boy out there, usually, he can be kind of contained. But if you've got a bunch of kids and they all gang up together, then you're kind of in trouble. And so separating them, making sure, bringing in more chaperones, you would do to kind of settle a system down, which are exactly the things we're talking about, making sure elimination is happening, making sure that the mind is as balanced as possible, that the kid has as much emotional support as possible. And then, we'll talk next about methylation and mitochondria, but that's kind of how I think about it. So did I answer your question? What I do for metals. Oh, and I was going to say in adults, I will do a chelated urinary check. So I'll give DMSA 1 gram and then have an adult collect urine for 6 hours. But that has the potential to mobilize things that then can cause more chaos. So I don't do that in kids.
Yeah. And I always tell with my patients, like I followed up with a 3-year-old autistic kid yesterday, and mom was asking me, when are we going to check for metals? And my response to her was, not yet. We're not going to check them yet. Like, we've checked them in the blood, they weren't there. We've checked them in the urine, they weren't there. But what's been stored is also a different story. I will give DMSA to a child. I base it, 30 milligrams per kilo, and I max out at 750 milligrams. And we always do like a trial, like give 100 milligrams, see how it goes, make sure there's no interactions. And then we just really have to make sure that kid is detoxing, because I don't want to mobilize and restore, right? I don't want the metals to then, just be displaced and not excreted. So I think it can be really important for children, though. I have a 4-year-old I've been working with for a couple of years, and she's the sweetest neurotypical kid. I mean, just sweet as pie. Been to endocrinology because she's a very, very slow grower. Thankfully, she's cognitively on task, and she's developing normally, but physically she is so tiny, and always had gut stuff, always had trouble with food, always had some dysbiosis, etc. So we've worked on her food and her gut for a long time. Well, every time I've checked her blood, there's been a 1 or a 2 of lead, a 1 or a 2, a 1 or a 2. And then finally, recently, I'm like, we got to do a provoked urine and see what's stored. And it was the highest level I'd ever seen. So I know that little girl has lead in her bones, and we got to get it out. And so now we're working, but she's in the best place to detox because all of the other systems are working, and I feel confident. And there is lead in all of those other family members, their blood. So there's a source in their home that they have to eradicate. They have to figure it out where it's coming from. So for her, it was really important. And my expectation is her growth takes off after we get the lead out of her system and get it out of her environment. So
absolutely. So that's the oxidative stress. Let's talk about methylation. Can you, for folks who don't know what methylation is, can you just, the elevator speech of methylation, and then let's talk about what that looks like for these kids?
Definitely. Methylation is something that I think everybody that treats patients should graduate with and know it so well. And the truth is, not a lot of people do. And it's foundational to our biochemistry. Methylating is a way of taking in a substance, breaking it down so that we can use parts of that broken down substance into other physiological processes. The whole thing that is really important in growth and development is how you methylate your folate, right? So B12 and folate are really, really, really important to build and repair your RNA and DNA. They're really, really, really important for the brain and the nervous system, more so than any other type of folate. And we know that, right? Because the government says, hey, if you're pregnant, you need to take folic acid. So everybody started dumping folic acid into the food supply. But the truth is, as you know, there's about 6 or 7, genetic steps to break down that synthetic form of folate into the methylated or bioactive form that's actually really helpful for your body to build on other processes. In neurology, it's, building your neurotransmitters. It's one of the foundational steps. You need those activated folates for dopamine, serotonin, you name it. So methylating is really, really important. And it is critical that you have enough B12 and folate in the right forms in your nervous system to do it effectively.
And so how do you check for that?
Well, it's interesting in kids, right? So in adults, you can look at that methylation pathway, the methionine cycle, with how you break down methionine into homocysteine or recycle it back into methionine. Well, from homocysteine, also remember, or I guess not remember, but if you imagine in your mind's eye, from that amino acid, you make all your detox chemicals too, down that transsulfuration pathway. So like we should be recycling our homocysteine. In adults, you can check it, so if you have hyperhomocystinemia, you can know, hey, you don't have enough B12 and folate to recycle this homocysteine. So, high levels of homocysteine in the endothelium or the blood vessels, when homocysteine hits those blood vessels, it causes stress on them and your body goes and builds plaque to repair it. So that's why it's become more of an accepted cardiovascular marker as well. But in kids, say I checked a homocysteine on a 3-year-old, it can be at a 2 or 3. Very, very, very low. And then I know that doesn't necessarily tell me that that kid has enough B12 and folate. And I don't think we know 100% why. So in the very young, it's not a really good marker. It's a marker for me to know, hey, you're not making your cysteine and you're not making your glutathione very well if you don't even have very much homocysteine. So we'll do that. I mean, you can look at it through organic acid. You can look at it through blood. But, if you have a kiddo that's on the spectrum, you also there's a part of you that should assume that they're not methylating well, because it's so common in this population.
Do you ever use FRAT testing, the folate receptor antibody test for cerebral folate?
I do. I often will find that in kids that aren't on the spectrum too, that they're positive. So that's some of Richard Fry's work. They did testing showing that if you have folate antibodies, you're basically not getting it into the brain as effectively. So the workaround from that is if you can just really give somebody a very, very, very high dose of folinic acid. So not methylated folate, but folinic acid. And as a prescriber, that's leucovorin, which if a pediatrician sees that a kid's on leucovorin, they might think that somehow you're treating them for cancer erroneously, because leucovorin is the rescue for methotrexate or being on cancer therapies, but it's just a vitamin prescription. It's just folinic acid. And unfortunately, you can't find high doses of folinic acid over the counter. I think maybe 2 milligrams is as high as you can find, but we're giving these kids, depending on their size, sometimes 25 milligrams twice a day of folinic acid. So it can be helpful. I think one of the things that I have gotten away from is maybe testing for it and just doing an empiric trial of it as much. And then also really encouraging that family to go off dairy. Because there's a correlation with you're more likely to have folate antibodies if you're eating dairy and you're sensitive to it, right? Just like if you're eating gluten, you're more likely to have thyroid antibodies and pathology if you're sensitive to it. So it's the same. It's probably why a gluten and dairy-free diet works so well for kids on the spectrum, and can, if you stick with it long enough and you're good at it, it's probably because it's allowing them to get more folate to their brain.
So that's the methylation piece. Let's talk about mitochondrial stressors. What are mitochondria? We've talked about them a lot in the show, but to kind of briefly review what mitochondria are and what things stress them and how do we look at that and what do we do about it?
Yeah. Okay, good. If there was a book only on mitochondria, and maybe you can tell me where to read it, I would. So the mitochondria are so fascinating to me. Yeah. I mean, just so fascinating to me. And they're, as you know, they're organelles or little structures within your cell that help you to produce energy. And energy in the nervous system is really, really important. So when there's a myopathy, that means that those energy factories are not producing as much energy or say ATP as they need to be. So it's complex, that mitochondrial respiratory chain. It needs lots of nutrients. It needs folates. It needs carnitine. It needs coenzyme Q10. It needs things to empower that chain to produce energy. And a lot of these kids, especially on the spectrum, they're deficient in carnitine. That's a huge one that they're deficient in. And they're also deficient in essential fatty acids. So they're not getting fueled or their mitochondria. And then they have a lot of stress. So if you're high on oxidative stress, eventually that toxicity is going to get within the cells, and eventually that's going to muck up the mitochondria to where you need to free those stressors around the mitochondria. I think it's really interesting that our mitochondria actually make oxidative stress just by the function of them working, right? So, antioxidants for the mitochondria can be really, really important. in a kid or somebody you think about with mitochondrial myopathies is, the kid that doesn't want to get up and play with the other kids, the kid that rather sit than engage in physical activity, the kid that might have, not only exercise intolerance, but sometimes you can have some respiratory manifestations with it. Sometimes it's just brain fog and fatigue that they'll have. And it's hard, a 6-year-old kid on the spectrum, you can't, it's hard to say, hey, are you feeling a little brain fog today? And often, an energy deficit in a child is hyperactivity. It looks different. It's counterintuitive to what you think. The hyperactive kids are the kids that actually need more sleep and more rest.
So how does that happen?
I don't know. I mean, think about the, 4-year-old that's running around like a maniac that didn't get their nap and they're just like running all over the room and they can't sit still. And then all of a sudden you look and they're asleep on the couch, I think it's that hyperactivity. They're trying to self-stim to keep awake and to not miss out. So you'll see that a lot with kids, and it's not energy. It's they're tired and they need to stop and refuel their batteries. And so that they can have a focus and calm.
I just wanted to loop back because we've talked about some pretty fascinating things between genetics, oxidative stress, methylation, mitochondria, nutrients. Like in the standard treatment for autism, if you go through the MCHAT and the ADOS and you're diagnosed by somebody and then you start ABA, what other treatments are often, what are the other common treatments for autism?
Well, there's only a couple that are FDA approved, and those are antipsychotic drugs. So Abilify and Risperidol. Mm-hmm. And, I don't want to shame any parent out there that has their kid on an antipsychotic drug, because sometimes the behaviors are so bad that they're so aggressive, they can't take them out of the house and they need support. Mm-hmm. I think what's missing and what is, what's kind of a shame to humanity is nobody is trying to figure out what are the things on that body burden that you can unpack. So maybe you don't take away the autism altogether, but all of a sudden, they can go to dinner with you and they're happy and they're sleeping and they're manageable and they are able to learn some, So those are the drugs that we have. A lot of times kids on the spectrum don't sleep. So we'll do things like cyproheptadine, hydroxyzine, which is another interesting point, because if you're doing really well on an antihistamine, I also think about what is your mast cell activation and what is your kind of total allergic load? And if we can decrease that, because at night it helps. I mean, histamine is stimulating, right? That's why Benadryl makes you tired, because it takes down the histamine. But there are other natural things and dietary changes that you can make to reduce the histamine load. So often for kids, we'll give cyproheptadine or hydroxyzine for sleep. And then some kids do really well on a selective serotonin reuptake inhibitor to increase the serotonin. Serotonin is happy and calm. And there are natural ways you can increase serotonin. As you probably have talked about with, amino acids like 5-hydroxytryptophan. My favorite, though, is sativa crocus. It's saffron extract. The research on that in the past 5 years has been beautiful. It's something that we've put in our formulations because it works so well. And I think it's kind of a natural SSRI. So there are things that you can naturally do, but some kids just need a little bit more support. And there's nothing wrong with that. But according to the FDA, you need an antipsychotic, and that's an ABA therapy, and that's it. Okay. So in the functional world, we think of things much differently.
We do. And so from the patients that you see, what do you see with outcomes with this approach? How much, do kids get better, and how much do they get better, and how many don't get better, and what happens over the course of a lifetime as they grow and develop?
That's a great question. And it depends on the child. So the truth is, the earlier the intervention, the better the outcome for certain. The truth is, if you have delays from birth, you're more likely to keep having delays and have a harder time with recovery. Some kids that have a regressive form of autism, you balance their body and they're on their way. Mm-hmm. Some of them, you balance their body and they just really struggle with high function things like social deficits and ADHD. Everybody that applies functional medicine to their health sees some type of improvement, but the range of improvement, it will differ with everyone.
Do you see kids who have been diagnosed with autism that essentially I don't know how else to say it, like just for the sake of the conversation, like become autism free? Or do you always see some kind of vulnerability or the waxing and waning course?
I think in a lot of treatment with any type of neuroencephalitis or autism, you're going to see some wax and wanes. Like you'll have gains and then you'll have a little regression and then gains. But if you get to a place that's typically very manageable. So there is some waxing and waning for sure. But there are those cases that, I meet with the parents and I'm like, your kid does not have I don't think they qualify for the diagnosis of autism anymore. It's really exciting when that happens. I don't want to give false hope to some parents like, well, I'm going to go to functional medicine and they're going to cure my kid's autism. Yeah. They will make your child healthier. They will improve their function within what their capability is. And sometimes that's the reversal of the diagnosis.
Tell us about some resources. Like if parents are out there and they're listening to you and they're like, well, holy cow, I should say. Like you've got a waiting list in your practice. Where can parents go? We've talked about your book, The Parent's Road to Autism, and we've talked about neuronutrients coming July 2022. Mm-hmm. What else can parents do to find, to get help?
So I love TACA, TACA. It's a organization that supports parents using a functional and biomedical approach to autism. It's a great support group. There's lots of resources. Parents usually mentor other parents going through this, and they really help them with the basics like, hey, this is what worked for my child, and here's the diet. And it's just a really beautiful collaboration of like-minded families that have had success really engaging with functional medicine with their autistic child. I am speaking at the parent conference that's in California in mid-October, and we're going to dig into PANDAS and PANS for kids on the spectrum. And so that's a good resource. Other resources, if you find, I think you were certified in 2014, correct? Mm-hmm. Yeah, gosh, I'd have to pull up my resume to know when I was. It was around that time. It's been several years. I think there's more and more pediatric providers on that Find a Practitioner on the Institute of Functional Medicine website. You can drop down and kind of see who's in your area. Anybody that's practicing family functional medicine should know the basics of really how to help your kiddo. So I think it just depends on your area, who you'll be able to see, but hopefully you can find someone on that practitioner website.
And before we go, I'm just curious, like, what is the research that you're seeing now that you're really excited about? Like, what are we seeing coming down the pike for these kids?
I haven't, I think that there's research that is in progress as far as like stem cell therapy for kids on the spectrum. Mm-hmm. I'm very interested in that. I'm kind of cautiously waiting. You'll hear things like, stories of great gains. I have some parents that are very, very, very strong believers in it because of how it helped their child. There's still some things in the United States where it's hard regulatory wise to get children's stem cells and how you get them, from what source, et cetera. But I'm excited about that. Mm-hmm. I'm just seeing what comes down, especially for those kids that have, a non-regressive form of autism. I think that they see more benefit with stem cells. So I'm curious about that. I'd really like to see more research with ozone therapy in kids that have a lot of oxidative stress. I think ozone medicine is really fascinating. I think it can be incredibly helpful. And I think more and more people are engaging in using ozone as a therapy for oxidative stress. I still am a huge believer in hyperbarics too for kids on the spectrum. Pressure, oxygen, putting more oxygen into the brain for healing, I think is really important. So I guess in terms of research, I'm watching the stem cell research. I'm watching to see what's going to come out. As we talked about too, I'd love to see more research of peptides in kids too. I'd love to see that. Peptides are being used in adults really has some wow to it. For increasing inflammation for sure. It's just not a lot of research in kids. So I'd love to see more providers using it and publishing on it for sure.
Absolutely. And peptides are strings of proteins. They mimic what's already in the body. So they're not patentable by pharmaceutical companies, which is why I think that there hasn't been a big emphasis and push behind them, but because of their molecular mimicry of the body, they actually can be fairly well tolerated. So for kids with, or adults with allergies or with mast cell activation, you're not putting in something that's foreign to the system. So sometimes they can be way better tolerated.
It's beautiful. And, in pediatrics, what's hard is they're a vulnerable population. So getting IRB approval and study approval to do something that's, hasn't been studied before is, it's a little difficult, So, but I'm excited about the efficacy in adults for sure.
One kind of last question is, do you think autism is this something that we acquire? Like, is this a dysfunction that is acquired?
It depends. I think we go back to the 80-20 rule. I think 20% of it I align with his beliefs that 20% really is genetic, but the 80%, there are genes, as you know, that we all have that can be triggered, and so what turns on those genes that causes dysfunction in our body. And if we can turn off those genes by balancing the body and decreasing the body burden, often then a child can grow and develop. Kids stop growing well when they're sick. And so if we can make them well and decrease their, oxidative stress, support their methylation and, really support their mitochondria, you have a lot of hope for them to function more optimally.
And we didn't really dive into a lot of this today, but just to mention, and maybe we do another podcast on this, but when we talk about that 20% of genetics, we're not talking about that old style, like one gene causes one disease, like one chromosomal change is Down syndrome or one sickle cell anemia. What we're talking about is a whole functional melee of genes. And we both use, one tool that we both use is that Intellex DNA testing, which we can find so helpful for functional genomics. Any other comments about that?
Definitely. I think that some of those genes have greater impact though. So if you have like a shank mutation, you're going to see more impact than if it's just a glutathione peroxidase mutation, right? So I wish we could say at this point in history in 2022 that, hey, we found the one gene that causes autism, but we need to be humbled. It is way more complex than that, way more.
Any final thoughts? Anything that this is so wide ranging and you are amazing. Any thoughts on anything else we should touch on before we close?
No, I just want to encourage parents to just take it one day at a time. All of this can feel very overwhelming. And, the truth is you didn't do anything intentionally to cause any type of delay in your child. Yeah. And, just one thing at a time. If it's today, I'm going to look for all the plastics that I'm microwaving. I'm going to take them out of my kitchen. And tomorrow we're going to work on, making sure we start using clean toothpaste and clean products. Like it's overwhelming. This is a lifestyle. This is a complete lifestyle change. And it doesn't happen overnight. It happens over time. Just like helping your child become the best that they can be, it's over time. It is not overnight. And it's not a linear process. There's going to be days where you're feeling great gains and others that you're going to feel discouraged. But I would encourage you not to give up and to keep just taking it one day at a time, and things should progress in a positive direction.
All right. Well, thank you all for listening today with Dr. Emily Gutierrez. We've got lots of ways to continue this conversation through Facebook, Instagram, and Twitter. You can get more information about her at her website, neuronutritionassociates.com, and definitely check out her new supplement line coming July 2022, neuronutrients.com. And you can get more information about us at our website, centerforhealingneurology.com. Please be sure to share this show with your friends. We welcome your rating and review wherever you get your podcasts, and feel free to send topic requests to podcast@centerforhealingneurology.com. We love that you've joined us today to discuss how to make our whole world medicine. We rise or fall together, and we're committed to doing what we can to make as many of us as healthy as possible. And this takes all of us, including you. So thank you for listening, and we'll see you next time.
Fish Media. Partyfish Media acknowledges that it operates and records on indigenous Duwamish and Puget Sound Coast Salish land that is still home to the Duwamish tribe. This land is stolen in violation of the Point Elliott Treaty of 1855. We are committed to uplifting the name of these lands and community members from these nations who reside alongside us. For more information on this land, its people, or ways you can help, visit duwamishtribe.org.